Welcome.
Thank you. Okay, I haven't started yet, so it might not go that way. But I would really like to thank Miha again for this opportunity to present. This is 2 years in the making. I was originally supposed to present 2 years ago until something got in the way. But I'm really excited to be here, and thank you all for attending. So as you just heard, we're going to be talking about what health departments can do to respond to an outbreak of Legionnaires' disease. So a little, make sure this works. Uh-oh. Uh-oh. Not sure why that's was working.
It was working.
Oh, there we go.
Just
It's the other button. Okay. Yeah, see, that's why you save your applause for the end. Anyways, a little bit about Phigenics. We are an independent water management consulting company. So we provide independent expert guidance for the development and implementation of water management programs to prevent building-associated injury and disease to improve operational efficiency. We provide real-time monitoring solutions, cloud-based data management, and environmental testing for all types of waterborne pathogens, and analytical services for water chemistry. We do not sell any water treatment chemicals, and we do not have any commercial affiliation with other companies that do so. So why are we here? Why are we talking about Legionnaires' disease? And I was looking at my slides just last night, and I've seen this chart so many times over the past couple of years. This is from the CDC. They published this. Well, actually, this specific chart is from the National Academies of Sciences paper on management of Legionella and water systems, which came out in 2019. But CDC has published variations of these charts before, and we keep on seeing cases and outbreaks of Legionnaires' disease go up year after year. And it's not going down. Certainly the pandemic didn't help our efforts to mitigate the potential for Legionnaires' disease or other diseases caused by waterborne pathogens. It is a still significantly underreported disease. According to the NAS, the committee conservatively estimated that the number of persons with Legionnaires' disease ranges from 52,000 to 72,000 in the United States each year. This is about 10 times higher than what is actually reported. So many reasons for that. But this shows that this is a serious problem. You know, everyone has rightly so been focused on COVID-19 for the past 2 years, and that's not going anytime soon. But there's so many things that we need to consider in the context of the pandemic with regards to Legionnaires' disease and water quality in our buildings. We see this all the time in news stories where a lot of Legionnaires' disease cases or outbreaks are being reported. It's not just a Michigan problem, it happens all across the country, happens in other parts of the world. Even in the happiest place in the world, you have 11 cases of Legionnaires' disease at Disneyland, and that was a couple of years ago. Several Michigan counties have reported increases of Legionnaires' disease every year. And it's a really difficult kind of issue to start thinking about when we're not really used to thinking about plumbing systems and water systems in our buildings having significant problems like this. There hasn't been as much discussion of this as, say, food safety, foodborne pathogens. But these are serious illnesses that kill people every year. Building closures, as I said, have not helped the situation at all. It was necessary to temporarily close certain facilities due to COVID-19 social distancing rules. However, this has caused significant water stagnation and left hotels, schools, offices, entertainment facilities vulnerable to the growth of waterborne pathogens and also chemical hazards. Reduced water demand results in microbial growth and disinfectant byproduct formation. And water demand decreased in many parts of the world. In commercial buildings, it decreased by about 40%, especially during the first shutdown orders. Microbial loads are associated with high temperatures, low total chlorine concentrations, and elevated levels of metals. And you can see here that around the time of March 2020, you had significant decrease in water demand. This particular study identified sampling for Legionella and other waterborne pathogens, and you can see that the incidence rate for, or at least the count of bacteria during just after a shutdown was about 6 log in magnitude. And only after several hours of flushing routinely were they able to bring it down even just by 5 log. So this really emphasizes the need for proactive water management and focusing on our building water systems. Long-term care facilities, healthcare facilities, they're especially vulnerable because they have the same kind of building water challenges, but they also have a sensitive population as well. In Quebec City in 2012, you had 180 patients in a long-term care facility that came down with Legionnaires' disease, with 13 deaths. And the source that they investigated was a cooling tower that was there. So 180 cases of Legionnaires' disease due to one cooling tower. And I'm not exactly sure what the issue was, but it's very important to keep focus on all kinds of water systems, not just your potable water systems, but your utility water systems as well. The financial cost from waterborne pathogens and illness is enormous. It's estimated about $434 million for claims annually for Legionnaires' disease infection, with total healthcare costs per patient of $38,000. And if you add in the other bacteria that cause disease commonly, like Mycobacterium avium, Pseudomonas, Acanthamoeba, it's estimated upwards of $1 billion every year for opportunistic building pathogens. So what are regulatory bodies doing to kind of tamp down this major issue? CMS, the Centers for Medicare and Medicaid Services, released requirements back in 2017 and then updated shortly after to require all healthcare facilities that are reimbursed through CMS, they must conduct a facility risk assessment to identify where Legionella and other opportunistic pathogens could grow and spread in the facility water system. They must develop and implement a water management program and specify testing protocols and acceptable ranges for certain control measures. That does not mean that they have to test for Legionella and these other pathogens, but they need to have a validation strategy for their program. A couple of other things to highlight from the CMS memo. They require an assessment of these types of water systems, such as faucet flow restrictors, shower heads and hoses, misters, atomizers, air washers, humidifiers, eye wash stations, hot tub saunas, decorative fountains, cooling towers, and also medical devices. Medical devices, Legionella is probably not the main culprit of healthcare-acquired infections. And that's why they included these other pathogens like Pseudomonas and NTM. So major issue that CMS jumped in. The Joint Commission also released a new standard. Joint Commission is an accrediting body that also requires water management programs as well. Inspectors, whether it's a health department or whether they're part of Joint Commission or another accrediting body for a healthcare facility, should inspect these water management programs and identify evidence that a facility has performed surveillance for occurrence of waterborne disease, conduct an actual risk assessment where they go through the facility and identify where there is a potential for hazards and hazardous condition growth, implementing a water management program and specifying testing protocols that also includes documented results of testing and documented corrective actions. Inspectors commonly ask about reports of disease, if there's any, caused by waterborne pathogens, a change in a facility's water source, water main breaks, any construction or renovation, the choice of sinks or fixtures, use of cleaning of hydrotherapy areas, cooling tower, treatment and operation, HVAC management, decorative water features, ice machines, and humidifiers, and also maintenance of other equipment that cause aerosols. Because Legionella is not transmissible from person to person. People acquire Legionnaire's disease when they inhale aerosols that are contaminated with this bacteria, gets in their lungs, and causes the disease. Hospitality industries, even before COVID, have struggled to adapt to the change in culture around water management. Facilities in the hospitality industry, such as hotels and resorts, also cruise ships, theme parks, they all have water systems that have the potential breeding grounds for Legionella and other pathogens. Travel-associated Legionnaire's disease outbreaks, these occur during the time when or directly after a patient traveled. And approximately 10 to 15% of all reported cases of disease in the United States occur in people who have traveled during the 10 days before symptoms onset. So hospitality industry also needs to take this into account. They don't have specific requirements like healthcare facilities, but this is still a serious issue that can cause people to get sick, and it can also harm their reputation. There are few proactive requirements that exist outside of the CMS memo for healthcare facilities. The implementation of these water management programs should be encouraged. So if you're working with facilities that are struggling with water management, water treatment, they have questions about water safety, they should be encouraged to develop a water management program. And we should also encourage the adoption of standards such as ASHRAE 188, which was published in 2015, has gone through a number of revisions in the past couple of years. I actually was on the ASHRAE 188 committee at one time, and these standards, while they're voluntary, they help to identify what should be included in a water management program and how they can improve public health outcomes. Surveillance and risk communication varies quite a bit from state to state. Not all states, approach things the same way. About 75% of health agencies have state-specific guidance for Legionnaire's disease surveillance reporting, but there are some gaps that were identified by ASTAHO a couple years ago. There's no common denominator usually, no common denominator data to calculate testing rates over time. It's not clear, usually from clinical or lab standpoints, who meets case criteria. There sometimes is difficulty in reporting to multiple federal systems, which eventually go up to the CDC, and sometimes they would get involved depending on the communication. And there's difficulty in interviewing each case or obtaining medical records. There's only 19% of responding agencies through the survey that have state-specific guidance for clinicians. And that goes back to what we were talking about, where there is this disease is severely underreported. And that's maybe one of the reasons why. Most agencies do not have staff dedicated directly to risk communication. They do have other personnel that take on roles during an outbreak. Many of you here may have been pulled into some of these cases if you work with health departments, work in a health department. If there's a case or an outbreak of Legionnaire's disease, they want to make sure that someone is there responding to it. It's not always the case where it's someone who is dedicated 100% to responding to these outbreaks. So a couple other steps to improve public health outcomes: encourage the use and adoption of ASHRAE 188 and other industry standards designed to mitigate Legionella growth. provide comprehensive training on building water system management, training to health inspectors. And health departments should have a common aligned decision-making and communication tools to support the consistency in responses to elevated cases. Some water management programs, if you have seen them in a building that has developed a water management program, they vary quite a bit also. Some are good, some have really robust procedures and prescriptive identification of what to do if there is an elevated count of Legionella in your system, and others are a little bit lacking. Some programs may only provide general guidance on what to do in the case of managing hazards from water systems. When the facility only has a general policy document saying that we'll respond to Legionnaires' disease cases, or we're going to contact the health department, if they have general guidance, there can be no reasonable expectation that the hazardous conditions in the building are maintained consistently. And effective water management programs, which Phigenics works with buildings and other industries to develop, provide a reasonable level of assurance that the desired outcome will be achieved. They should be routinely reviewed and evolve over time to ensure necessary control measures are carried out consistently and expectations are being met. So, how do you make a sufficiency determination? So, first and foremost, the water management program should include the 7 steps of a comprehensive and defensible water management program, which starts with forming a team, developing program goals, describing the water systems in the building, similar to that list that we saw that CMS put out, analyzing the water systems for safety and efficiency, and also the potential for hazard growth and hazardous condition accumulation, specifying specific control locations, control limits, monitoring, and corrective actions, developing a verification strategy, and then developing a validation strategy. Verification means making sure that the program is implemented as designed. Validation, we mean, is that the program is effective as designed. And keep in mind a couple things. A water management program on its own is nothing without verification validation records. And on the flip side, verification and validation records are nothing without the water management program. So if a building is saying, or a facility or a property manager is saying that their mitigation strategy is to test for Legionella and to see that if they have it, that's not sufficient. They need to have a program and they need that validation data to inform observations about the program. So it really needs to have all these steps that are detailed in ASHRAE 188. So performing environmental investigation. So when we're talking to buildings or facilities that have a potential case or outbreak of Legionnaires' disease, there's a couple things that we want to keep in mind, and that's what I wanted to really focus on for today's presentation. So CDC recommends a full investigation for the source of Legionella in a facility upon identification of at least one case or more of a definite healthcare-associated Legionnaires' disease at any time, or at least 2 or more cases of possible healthcare-associated Legionnaires' disease at any time. It's important to use a 12-month time frame for linking possible healthcare-associated cases. Sometimes you'll have a number of cases during the summer months when Legionnaires' disease cases seem to spike quite a bit due to warmer conditions, changes in the potential source. But you might have a couple months later, there could be other cases. And so you want to tie them all together because, again, it's coming from potentially the same water systems. So you want to make sure that you're incorporating all these different cases to get a better sense of what is going on in the facility. There should be an increased sensitivity account for periodic changes in the risk of growth and exposure, such as seasonality. And cooling towers should also have a shorter time frame because those systems can seriously grow Legionella quite rapidly. Information during the investigation that should be collected should include the date of symptoms onset, travel history, history of exposure to other high-risk sources, risk factors, exposure dates, occupation, and place of residence of attendants in the facility or institutions. And there's another factor that we should also consider that is relatively recent, and one of which would be, has the facility been shut down for an extended period of time? So due to COVID-19, has this office building, has anyone been using the water for several months? Still a lot of offices, a lot of schools, a lot of facilities are still not using water, as much water prior to March of 2020. So that should also be considered. Who should be involved? On the public health side, you should have the district epidemiologist. Usually they're the single point of contact for communication. The state Legionella coordinator, if there is any. Again, states vary on how they identify roles. The testing laboratory that is going to be receiving samples, and health department inspectors. On the healthcare facility specifically, you should have the infection control manager, who should be the single point of contact for communication, the full water management team that's formed, hopefully at the start of the water management program development, facilities management, the medical microbiologist, clinical engineering, environmental health, and the case patient or their proxy if they are not able to communicate. So when you're doing a clinical investigation, it's important to contact the case patient or the proxy within 7 days of the report in order to get that information that we talked about a few minutes ago. Interview regarding the overnight stays, any pool and spa use, treatments received, and their occupation. Also, if they spent time in a building that has been shut down for an extended period of time. What are the goals of the environmental assessment? So we might think that the goal is to find the exact location where the Legionnaires' disease outbreak or case originated from. And technically that is the goal, but there are many cases where during investigation you don't find that source. You don't make a definite conclusion. Water systems fluctuate quite a bit. And what may have been the condition during the time someone was exposed to a contaminated aerosol, those conditions may not be the same during the investigation. So it is challenging, but what we need to identify is the most likely source of an outbreak or case. We want to gather all supporting documentation that is available, such as the water quality monitoring, if any, Legionella sample results, maintenance and cleaning records, and vendor reports. Basically everything that should be part of a verification program. And identify potential critical control points. ASHRAE 188 calls it control locations. So these are areas where you would implement a control to mitigate hazardous conditions. So something as straightforward as disinfection for a utility system, that's a control. And that would be a control location. So where you inject chemicals or do other kinds of methods for mitigation. Questions to ask on site when you're doing the investigation. First and foremost, does your facility have a water management program? If they do, great. When was it last updated? If it was last updated 5 years ago, it's probably insufficient. Or, we want to make sure that these programs are being used, that they're evolving constantly. Was the water management program developed based on current guidance documents, such as ASHRAE 188? This is the CDC toolkit, which is based off of ASHRAE 188 requirements, very user-friendly. And then we also have the ASHE monograph, ASHE for the Society for Healthcare Engineers. Who developed the water management program? It's good to understand that, whether it was developed internally or it was developed by a consultant or a water treatment vendor. And is it site-specific? That's almost the most important thing to understand. Remember, we want to make sure it's not a general policy general policy document that just refers back to emergency responses. So what are they doing specifically in their building to mitigate these hazardous conditions? A couple other questions to ask on site. Are there any areas of tepid water temperature? So Legionella and other pathogens grow best in tepid water, around 35 to 45 degrees Celsius. Are there any points of stagnation and low flow, especially for buildings that have been shut down for a long time? There's definitely the potential for stagnation. Is the release of water spray controlled? Remember, aerosolization causes people to acquire contaminated droplets contaminated with Legionella. Are there areas of accumulated sediment in the system? Are medical devices, if they have any, and outlets disinfected to control biofilm formation? Is it possible for cooling tower emissions to be drawn into building air intakes? Are there risks associated with thermal flushing, restarting the water system, or construction? So is there a potential for dislodging biofilm that's collected in the internal components of your building system? And what types of water treatment are used, if any? Probably most of the time, a building's not going to use a supplemental disinfection, but sometimes they will. So that could include many things like thermal disinfection, copper-silver ionization, ultraviolet radiation, ozone, chlorine, monochloramine, chlorine dioxide, a lot of different things. Also filters. Do they have filters that are used for removal of sediment or even Legionella? So a couple other questions for asking about the specific water systems. What are the potential hazardous conditions associated with the water system? So when you talk about hazardous conditions, those are things like sediment, temperature, water age, the disinfectant residual. Are any of those factors enough to cause Legionella growth? Who may be exposed to the water through inhalation and for other pathogens, ingestion, and even skin contact? Who should be responsible for the water systems? What is the frequency of use? Does a plan need to be developed for the management of the water system? ASHRAE 188 was published in 2015. Still, a lot of buildings do not have a water management program. And what verification and validation requirements are required? Are they documenting what they're doing? Are they testing to ensure that the program is effective as designed? So some water management programs may only include general guidance and suggestions on how to approach the evaluation and management of hazards in a building water system. And when the facility only has that general policy document, there can be no reasonable expectation that the risk is being managed consistently. Detailed water management programs should always have defensible records that provide a reasonable level of assurance that the desired outcome will be achieved. Water management programs should be evaluated to ensure necessary control measures are carried out consistently and expectations are being met. And the water management team, should refer back to the water management program and records during an investigation. And that's something that the health department investigators can help with. Example of control locations that may exist. A lot of different possibilities. I mean, even if you take this hotel or another facility as an example, a lot of different points where you can come in contact with water. Not all locations may be treated the same. There may be a higher risk for exposure during a shower than there would be a drinking fountain. But still, we want to identify all the potential control locations. Facility areas that should be reviewed. So locations where aerosols can be created, such as showers and taps, decorative fountains, spas, cooling towers, humidifiers. Areas that contain water at temperatures between 68 and 122 degrees Fahrenheit, or 35 to 45 degrees Celsius. Stagnant water, dead legs, poor water flow, infrequently used outlets or fixtures, and also any construction, renovation, or maintenance sites that may have disrupted the water system or dislodged biofilm. water restrictions. So a lot of the times, going back to the idea of approaching water management from an emergency point of view, a lot of the times facilities will find Legionella in their water system, or they may find there may be a potential case where someone was exposed to the water system at their facility. What shouldn't happen is turning off your water system entirely. Water restrictions are important, especially if someone could be exposed to things like showers, spas, but you want to keep water flowing. That's one of the main reasons why Legionella grows in a facility, building water system so well, is that there is that potential for stagnation and water age. So the potable water supply should not be turned off. You can restrict use of showers, other aerosol generating devices, but keep regular maintenance, keep the regular routine maintenance going. And if we're talking about the domestic drinking water, you can always revert back to using bottled water. Environmental sampling, it's another big question that we get all the time. Environmental sampling should be based on the risk assessment and identification of control locations. Again, so the risk from exposure to contaminated aerosols from a drinking fountain is maybe not the same as a shower or a cooling tower. So you want to really identify where are the potential control locations that need environmental sampling. So it should be based on that risk assessment, and the sample points should be continually reassessed as the investigation progresses and more results are collected. I've been involved on assisting with potential cases of Legionnaire's disease at facilities, and you don't have to keep sampling the same locations. You switch it up. You try to identify where is that most likely source of exposure and or growth. You want to follow up on environmental sample results with clinical surveillance. So you want to ensure the availability of lab tests for Legionella, whether you're doing culture or urinary antigen tests. You want to determine or develop your facility's strategy for clinically identifying cases, facility-associated cases of Legionnaire's disease. All patients or people who may be staying at a facility who are at greatest risk or moderately increased risk for acquiring Legionnaire's disease should be tested for Legionella if they develop a facility-associated pneumonia. So again, we want to look at that 12-month time frame. We want to see what kind of patterns we're seeing. If someone has a case in a long-term care facility of Legionnaire's disease, it's likely someone else may be exposed to the same water system, and if they require pneumonia from the facility, it's really important to make sure they get tested as well. And we want to educate all clinicians to perform testing for Legionella for all patients who develop pneumonia or culture all respiratory specimens that are received by the lab. So a lot of teamwork, a lot of different stakeholders that need to be involved, and we all need to be on the same page as much as possible. So we want to monitor patients and follow up with Legionnaire's disease diagnosis. It's important to obtain chest x-ray as clinically indicated. Number of different ways we can test patients, just for your information. We want to culture for respiratory specimens for Legionella species. Now, you might say that most cases of Legionnaire's disease are caused by Legionella pneumophila, which is true. But if you see another Legionella species in your facility water system, maybe it's not going to necessarily cause an outbreak, but if you find one Legionella species, you can probably find some other ones. You want to detect urinary antigen for Legionella pneumophila serogroup 1, which is the group that causes 90% of Legionnaire's disease cases. We want to alert the laboratory when requesting culture for Legionella species, as special media must be used for isolation of the organism. And especially during clinical investigations, we want to save the isolates from respiratory specimens since they are necessary in facility-associated Legionnaire's disease investigations. We want to tie in the specific strain of Legionella that caused the disease to the environmental sample. So we want to save all these we want to save at least the isolates that are taken from the patient. It's important to follow up with the facility. We want to make sure that they are developing their program, they're using their program, and they're doing things, they're taking measures to reduce the likelihood that there could be additional issues. It's not necessary at all to await the results of sampling before undertaking certain control measures, particularly if inadequacies have been identified in the management of potable water system, medical equipment, or cooling towers. We don't want to wait for a non-detect or even a detectable result. We can start implementing control measures to mitigate hazardous conditions. We want to promptly implement control measures and monitor their effectiveness. And ongoing control measures and remedial actions need to be documented because that is the only way it will be defensible. So if they don't have records saying this is what they did, then there can be no reasonable expectation that there's consistent water management carried out. And